afternoon, Barcelona. I think we are listening to me. So for me, it's a great pleasure to introduce Professor Manuel Romero. He's a good friend coming from Sevilla, as all of you know. He's Professor of Medicine, Chair of Medicine at the University of Sevilla, and he's an expert in the field of several things in hepatology, encephalopathy, hepatitis, and especially non-alcoholic steatohepatitis. He has a lot of publications in the field of non-alcoholic hepatitis. He is leader of several projects, a Spanish project, a coordinator or co-coordinator of European projects in this field. So thank you for coming, Manolo. It's a pleasure for me that you are here.
Yes, thank you, Rafa. Thank you very much. I'm absolutely proud to be here. It's a fantastic experience, and I would like to thank Jordi Gracia and Rafa Bañare for inviting me, giving this opportunity to spend this morning discussing many aspects of not just non-alcoholic steatohepatitis, is beyond the metabolic disorders, but enjoying a lot, learning, teaching a little, but learning and sharing a very, very nice experience. I hope this fantastic program will be continuing in the next future. I like to give you many information, to discuss with you many things about non-alcoholic steatohepatitis. I was initially thinking which is the best focus on this, addressing this disease, just a clinical point of view, our translational point of view, or our basic point of view. At the end of the day, I make decision to discuss with you what is the state of the art of the key point, the key controversial point on this disease from a clinical point of view. I think it could be useful for the clinician and also for basic research. I'm discussing the burden of the disease, the dynamic of the phenotype is two key concepts on the histology that until now is the gold standard for the diagnosis of this disease. I'm trying to convince you that we have many tools that we can put together in an algorithm for the diagnosis of NAFLD-NASH. Also, the concept, the idea that NAFLD-NASH affects beyond the liver and is a multisystemic disease. And finally, the management of this disease. I like to start with this clinical case. It's a 66 years old patient, arrived to my outpatient office 1 year ago, suffering from obesity, unrecognized type 2 diabetes, no allergy reaction, hyperlipidemia, Barrett, and suffering from symptomatic cholecystitis. And I make decision to undergo surgery, and a laparoscopic cholecystectomy was done. The surgeon called me during the surgery and sent me these two photos. I was absolutely surprised because the surface of the liver is nodular. You can see a typical characteristic of cirrhosis in a patient without any previous suspicion of cirrhosis. And this is the key point, the key aspect in the burden of this disease. Many times we are thinking around a third of the American people suffering from NAFLD, a quarter in Europe, a fifth in Asia. Even if we are calculating in Spain, the general population, around 10 million people suffering from NAFLD, and we can think there are many people suffering from this disease, but how many patients are suffering from advanced fibrosis? The most surprising data is that we can calculate 1.4 million Spanish people suffering from NASH and 0.3 million cirrhosis. 300,000 people with cirrhosis is the largest outbreak in comparison, for example, with hepatitis C, in which we are spending many effort in the last 30 years. Therefore, we need to keep in mind that this is the collision of two outbreaks, diabetes and obesity, promoting many patients with NAFLD is not the major problem. The key point is the large number of patients with cirrhosis. In these two epidemiological study trying to analyze the percentage of patients with NASH and advanced fibrosis in this in these three different cohorts, in obese people, NASH is around 22%, but advanced fibrosis is 11%. When if you calculate how many obese people, you can figure out the size of the problem. In type 2 diabetes, 2/3 of the diabetic patients show NASH in the liver biopsy and 15% advanced fibrosis. But when we put together obesity and type 2 diabetes, near a third, 28% of these patients suffer from advanced fibrosis. In an epidemiological study in the Nottingham area that is in press in alimentary next year, they called 20,000 people, selecting just a patient in this area with diabetes, obesity, or with alcohol consumption higher than 21 units of alcohol per week in males or 14 in females. At the end of the day, 900 came to the primary care center to undergo transient elastography and was successful in 900 patients. And you can see the percentage of patients with cirrhosis is depends on the collision of all these problems. In the green, in the pink column, in the last column, in patients with type 2 diabetes, obese, and with a third dose alcohol consumption, 13% suffering from cirrhosis, not just advanced fibrosis, cirrhosis. Of course, if you combine, for example, type 2 diabetes and obese, it's 6.6%. This is a cohort of patients belonging to the general population in which any patient now suffering from liver disease were excluded, and this is the true prevalence. This is a large number of patients and a big problem. The second aspect I would like to discuss with you is how are we interpreting liver biopsy. We have three major hallmarks for this disease: steatosis, ballooning, and fibrosis, and we are very interested to know and to detect. The first change in the interpretation of the steatosis was included in the SAF score by Pierre Bedossa, demonstrating that the amount of fat doesn't matter. The key point is our patient showing fat in the liver? Yes, the patient suffers from NAFLD. Later we need to demonstrate steatohepatitis and fibrosis. If the patient didn't show any steatosis, the patient did not belong to this group of disease. And this is very important because the large number of hepatocytes with lipid droplet did not mean a more aggressive or a more severe liver disease. We can detect the steatosis just to define the patient is suffering from NAFLD using non-invasive method in the Spanish registry, including 441 patients, using hepatic steatosis index and ultrasonography. Yes, is the score is higher than 36 or the liver is showing hyperechogenicity. We can detect using one of these two methods steatosis in 99% of patients suffering from steatosis. We have two non-invasive methods, free or very cheap, close to our patient office, in which we can confidently detect steatosis. But also we have the opportunity to use CAP in this meta-analysis, individual patient data meta-analysis, in which CARLAS include more than 2,700 patients of different etiology and calculate the diagnosis accuracy of CAP. The control attenuated parameter is a software included in the FibroScan. Using the same machine, we can calculate the stiffness in kilopascals and also the controlled attenuated parameter, the CAP, in decibelius by meter. And the diagnosis accuracy in this meta-analysis was much better than the previously reported diagnosis accuracy in a small cohort. And to detect steatosis, the accuracy is higher than 0.82. The rest is interesting, but it's not relevant. And for me, in this study, they demonstrate clearly that at least 3 variables influence on the result of the CAP: the diabetes, the body mass index, and the etiology. And they propose that we need to recalculate CAP according to this variable. In patients with NAFLD-NASH or in patients with diabetes, we need to deduct 10 decibelius by meter to recalculate CAP and to diagnose steatosis. For the body mass index, it depends on obese people. We need to deduct, and in lean people, we need to add 4.4 units depending on the distance to the 25 kilo per meter square, the ideal body mass index. We can recalculate CAP value, and the threshold to diagnosis steatosis, fat infiltration in the liver, has been established in 248. It's mnemotechnic, very easy to remember. 248 decibelius per meter square, divide patient with and without steatosis. But at this time, we need to analyze the liver biopsy to achieve the diagnosis of NAFLD-NASH, and this gold standard shows several limitations, several weaknesses that I'm not very interested to highlight more than enough, but we need to keep in mind all time when we are analyzing the liver biopsy in outpatient office. In this study by Blood Ratio, more than 12 years ago, 51 patients that underwent 2 liver biopsies were analyzed separately. They demonstrate that the concordance between both liver biopsies in the same patient in the same time could difference in one stage of fibrosis in 41% of the case, 41, and the patient could show advanced fibrosis, bridging fibrosis in just one of the in 3 liver biopsies. You can diagnose advanced fibrosis in a patient if you take the liver biopsy in the right lobe or in the left lobe. You cannot detect advanced fibrosis. It's very important because you know fibrosis is absolutely relevant in the natural history of the disease. But a second very, very important concept has been emerged from the study from Macpherson and Quentin Asti in Newcastle. They analyzed liver biopsy in 108 patients, 6.6 years apart, the first and the second liver biopsy, and they demonstrate that 44% of patients that was diagnosed as a sample steatosis, bland steatosis, in the first liver biopsy progresses to steatohepatitis 6.6 years later, and just 7% regress from steatohepatitis to steatosis. It means that this disease is not a photo. When we are doing a liver biopsy, we are having the information of a photo, but this photo is included in a movie. It's a continuous change, and this is the 2 main concepts that I would like to transmit you, to give you this afternoon. The first one is it's very common, the overlap between these 3 histological features: steatosis, ballooning, and fibrosis. The higher fibrosis, the higher inflammation is very common. Even you can find that the higher steatosis is overlapped with the higher inflammation, and it's very rare to find a pure steatosis in the liver biopsy. And the second one is the dynamic chain, this idea passing from the photo to the movie. And it's very common that the patient could progress, and we cannot make a final decision with just one interview, with just one liver biopsy, and we need to analyze exactly what is happening over the time. The second hallmark is ballooning. Is fascinating for us. Ballooning means the hepatocyte is very, very sick. I like this comment from Stephen Caldwell in Virginia, that the hepatocyte suffering from balloon degeneration is too sick to live, but too weak to die. You know? It's a cell that it doesn't work, could not work, but could not die, could not disappear completely. It's a failure in the multi-organelle, affecting many organelles, including lysosome, endoplasmic reticulum, and a process losing completely the cytoskeleton, and for us has been very attractive from the pathological point of view, and also using as a potential biomarker, or looking for biomarker that could give us information what is happening in the liver and if ballooning is present. But all epidemiological studies that you can review in the last year appear at least 4 different studies with a large number of patients, all of them with liver biopsy, followed for more than 10-20 years, demonstrate that the only histological feature and perhaps the only clinical variable associated with the progression of liver disease, with the survival, was fibrosis. Fibrosis F4, F3, F2 were associated with shorter survival, and F1, F0 show a similar survival in comparison with general population. Therefore, we need to do all our effort to detect fibrosis, to know if our patient is suffering from significant fibrosis, advanced fibrosis, or cirrhosis, because these patients are in risk of mortality or decreasing survival. To address this point, we have many non-invasive methods. The 2 most frequently used in clinical practice are the NAFLD fibrosis score and the FIB-4. They are very useful in clinical practice. We can screen in general population. They are very potent, saying which patient did not show any data of fibrosis, and fibrosis could be excluded and the patient could be discharged. But the main limitation is the wide gray zone. Many people give a result that is uninterpretable, and we cannot make decisions. Using also the Spanish registry, we developed the EPAMET fibrosis score. EPAMET is the name of the Spanish registry. And using this variable, that are variable very common in clinical practice, the majority of them include in the 2 previously showed, the NAFLD fibrosis score and the FIB-4, and the only next one is the HOMA. HOMA is a very important parameter, monitorize the metabolic condition, and I think it's strongly related with fibrosis. And when we calculate EPAMET score, we achieve a better diagnosis accuracy. The undercurved area for significant fibrosis, advanced fibrosis, and cirrhosis is higher and significantly better in comparison with NAFLD fibrosis score, APRI, and FIB-4. But the worth of this method is how reduce the gray zone, and less than 10% of the result belong to the gray zone. Lesser than NAFLD fibrosis score is a third, or FIB-4 or APRI is around a fourth of a fifth. No? We have very nice diagnosis accuracy between 0.78 to 0.93 and a very narrow gray zone. I think it could be very useful in clinical practice, and for a general practitioner it could be useful addressing general population and in patients with obesity, type 2 diabetes, hypericogenicity in the ultrasound, metabolic syndrome, or altered liver function test. We can use these 3 methods, and in patients in which at least 2 methods demonstrate they are under the lower threshold, we can exclude fibrosis, and the patient could be discharged. And in patients in which at least one of these 3 methods show a result higher than the upper threshold, we can confirm the necessity of exploring fibrosis. And to do this exploration, to know exactly the fibrosis of our patient, we can use imaging biomarker. They are working very well at this time. We have two types, based on ultrasonography or based on magnetic resonance. In the ultrasonography, we have FibroScan with the CAP, the control attenuated parameter that I showed you before, the supersonic, and also the ARFI. All these methods show a similar diagnosis accuracy, but FibroScan is very, very extensively available in the majority of clinical centers. We have many data, and we know exactly the limitation of FibroScan is included in clinical practice. In magnetic resonance, we can use magnetic resonance with 4 different approaches. The PDFF, the proton density fraction, to measure the percentage of fat infiltration. The MILI, detection of metabolic induced liver injury, is a software developed in the University of Sevilla and the public health system, and we can achieve 2 outputs, NASH MRI and FibroMRI, giving us information about the presence or absence of NASH or fibrosis. The liver multi-scan is also a software from the University of Oxford. At this time is in the market by Perspectum Diagnostic. Is a spin-off of the University of Oxford, and using also magnetic resonance, we can, they release the LIF, the liver inflammation and fibrosis score. And finally, magnetic resonance elastography is also a promising method. It's not available in Spain yet, but I think in the near future we can have many patients undergoing these studies. When we compare what can we give magnetic resonance in comparison with CT or ultrasonography, we can do many things. We can use different sequences, and we can achieve very relevant information when studying the liver using magnetic resonance. Using magnetic resonance, we can calculate, quantify fat infiltration, iron, inflammation, the presence of biliary fluid, or fibrosis stage. We can add to the magnetic resonance the elastography, we can add the optical analysis, is the MILI, we can add T1 mapping, is the liver multiscan, the diffusion weighted image is also a very interesting sequence, and we can analyze liver function and the perfusion of the liver. And all these parameters could be used together with magnetic resonance. This is an example of the proton density fraction. Is the idea to have a sequence with an image saturate of fat, an image of saturate of water, and corrected by T2. Correcting by T2, you can exclude any confusing, any noise due to biliary, due to iron, etc. And with this protocol, we select a ROI, an area of interest in the liver, and we calculate exactly the percentage of fat infiltration. This method allowed to measure several ROIs in the liver, and recently Heikki Järvinen from Helsinki demonstrated that the fat infiltration in the liver is different in the right lobe and the left lobe. I'm not sure if any political issue could explain this difference, but you can measure the infiltration of the liver in many areas, and is superior to liver biopsy. For me, I'm confident in the result of the PDFF with a higher confidence, much better in comparison, for example, with the liver biopsy, because we can analyze the wall of the liver. The second protocol is the liver multi-scan, is also the multiparametric magnetic resonance image. In this liver multi-scan, they do a T1 and corrected by T2. T1 mapping could allow you an image of the T1 of magnetic resonance, and you need also again to correct by T2 and exclude iron, exclude any noise, and this corrected T1 spin is the LIF, is the liver inflammation and fibrosis score, is the output of this method, and you can use in clinical practice in a similar manner, quite similar to FibroScan. It's a continuous variable, and you can demonstrate if decrease with the treatment or increase during the follow-up. This is the original study by Banerjee, demonstrating a correlation between lift and fibrosis using the Ishak until stage 6, and you can see how normal liver show a lower result in comparison with F1, F4 and lower than cirrhotics. But you can find a great overlap. I don't know exactly great. It's an overlap between F1, F2 and F3, F4 using the Ishak is just in non-cirrhotic patient. In this second study published this year in Journals of Hepatology, demonstrate a correlation of the LIF with the NASH score and also with ballooning, but again with some overlap. As you can see, no ballooning show a very low result, but degree 1 and 2 they are overlapping. You can see in the third draw, in the third graph, how PDFF correlate perfectly with a percentage of fatty liver, the steatosis, and it's a very nice method for this diagnosis. The last study using liver multi-scan was trying to demonstrate how LIF higher than 2 was associated with events, different outcome in the follow-up of this patient. The cutoff is 2, and they can separate perfectly patient with normal liver, no NASH, no fibrosis, is around 1, but patient with or without NASH, together with fibrosis or both, you can see how again is higher than 2, but overlapping the result. This is a promising method. We can analyze together inflammation and fibrosis. We have a result that perhaps we can compare what is happening in the future with this patient, or if the patient is responding or not to the therapy. The MELI is the method that we published in a scientific report last year using 3 standard protocol of magnetic resonance. We can analyze 6 slides per protocol, 1500 around 100 sample. One sample show a volume around a liver biopsy, and we keep in mind that we are analyzing 100 liver biopsy in each patient. We use the optical analysis. It's a software analyzing exactly what is the result of 3 different parameters that can analyze the bright, the contrast, the color, etc. are optical parameters, and taking account these 3 protocols and the different parameters, we can calculate fibro-MRI and NASH MRI, both between 0 and 1, and under 0.5 means no NASH, no fibrosis. Over 0.5 means NASH, means significant fibrosis. The undercurve area is around 0.85 or 0.84. It's a very nice result. You can see here that NASH MRI did not show any overlap between patient with and without steatohepatitis, and works much better than, for example, cytokeratin 18 in blood. Fibromyalgia show two very interesting features from my point of view. The first, you can see a correlation with the fibrosis stage, is F0, F1, F2 or more, and fibromyalgia is increasing. So this the diagnosis accuracy around 0.85, but we sent to the Spanish liver meeting and the European liver meeting how fibromyalgia correlate with metabolic feature. And this thing that we are looking at in the liver using an optical analysis correlate positively with the HOMA, with a coefficient of 0.83, and also with HDL, no, in the negative correlation, because the lower HDL, the worse situation. From my point of view, reinforce the usefulness of the mucin, NASH MRI, and fibromyalgia in the management of the disease. And the final method is elastography, magnetic resonance elastography. You can see here is a device over the liver showing giving a mechanical wave. This mechanical wave moves across the liver. Depending on the speed of this wave, we can calculate the distribution of fibrosis. The first idea I would like also to highlight is how so heterogeneous is the color map in this exploration. Blue means F0, red F4, and you can find all these colors in the majority of these studies. We can define threshold to classify patients according to different stages of fibrosis, and in United States and Japan, where the main a large number of MRE systems are available, we can define this threshold, and until now we have a very, very high diagnosis accuracy, close to 1, and we can correctly classify patients using this method. I think in the near future we will start working with them. No? This is a study from Stephen Harrison, in which in clinical practice try to analyze what is the ability for the diagnosis of the different stage of disease, comparing liver multi-scan, FibroScan, and magnetic resonance elastography. It includes 673 patients. At the end of the day, 449 underwent the IMaging biomarker. In patients in which they demonstrate any alteration, liver biopsy was proposed, and in the majority of them, no liver disease was found and no liver biopsy was done. 328 patients show a normal liver and no liver biopsy, and 160 underwent liver biopsy. 63 with NAFLD without NASH, and 58 with NASH. This is the how works FibroScan and magnetic resonance elastography, and you can see how between F0 and F1 we cannot find many difference, but after that increase with liver fibrosis. And in this table you can see the ability of this method to calculate fibrosis, steatosis, and NASH. For fibrosis, the magnetic resonance elastography is around 0.83, 0.96, for example, for F3, F4 is a very high, very interesting result, much better than the other two. For steatosis, the PDFF is fantastic. Proton density fan fraction allow us to accurately diagnose fat infiltration, and the unmet need is to recognize NASH using FibroScan, magnetic resonance elastography, or liver multi-scan leaf, would not reach a diagnosis accuracy enough to implement for this proposal. 0.61, 0.58, or 0.71. It's an unmet need to develop an IMaging biomarker to detect steatohepatitis, and I think it's a place for DEMILI in clinical practice. And the fourth topic that I would like to discuss with you is NAFLD NASH as a systemic disease. We can overwhelmed due to the large number of patients, the large number of cirrhotics, but also this disease affects beyond the liver. Could affect the bone osteoporosis, sleep apnea, abdominal obesity, cardiac abnormality, and arrhythmias, PCOS, psoriasis. But the four most relevant extrahepatic manifestations are the chronic kidney disease, with a very strong correlation between both cardiovascular disease, type 2 diabetes, and extrahepatic malignancy, together, of course, with the outcome related to liver outcome. This is a meta-analysis from Javier Ampuero demonstrating how NAFLD demonstrated by liver biopsy was associated with clinical atherosclerosis, increasing the risk by 4 times. And this paper from Journal of Hepatology in the last month demonstrating that patients with NAFLD, more than 25,000 people followed for 7.5 years. The appearance of neoplans was higher in NAFLD versus non-NAFLD, but especially colorectal cancer was increased by 2 in males, the breast cancer by 2 in females, and the hepatocellular carcinoma by 16 times in both, in males and females. Therefore, this disease could catalyze, could promote the appearance of diabetes, chronic kidney disease, but also extrahepatic malignancy. Many things we are doing many works trying to implement precision medicine in NAFLD-NASH. We use several approaches: genome analysis, epigenetic, transcriptomic, metabolomic, proteomic, of course metagenomic and microbiota, and the exposome, the environment. We analyze many parameters, but at the end of the day we did not reach any specific marker able to be implemented in clinical practice. PNPLA3 is strongly related with NAFLD-NASH, but the odds ratio is 1.5. We cannot segregate general population according to the genetic background in which we need to screen or not the disease. The validation study of the different biomarkers, for example, lipidomics or even epigenetics, microRNA, long non-coding RNA, it's very difficult to confirm the result of the other lab, and we need to improve the methodology, we need to improve the knowledge about the role of these different parameters on the progression, the diagnosis, and the therapeutic response in this disease. The same for the metagenomic. The microbiota is a field in which we need to look for many information. We need to ask many things, because the interaction between the microbiota and the intestinal barrier, and also, of course, the immune system is absolutely crucial, and I'm sure in the future will give us many information. And this time we are just calculating the rate between Firmicutes and Bacteroidetes, and we need to move ahead to feel it, to now much better what is happening in the intestine. Even, for example, we can divide the phenotype or the genotype much better of the patient according low microbial gene count or not, and low microbial gene count could be associated with NASH, but it's a very grotesque, it's not a elegant manner to analyze, and we need to move up here to learn a lot about microbiota and about the alcohol, diet, and physical activity. We need to also to separate much better which is the role of each of them, and at this time we have a very big overlap between NASH and non-alcohol, because many patients could drink alcohol, and we need to better define exactly how we need to address this questionnaire. How can we know exactly how much alcohol is drinking our patient? And the second one, to define the threshold to responsabilize alcohol of the disease and exclude non-alcohol liver disease. Finally, the management of NAFLD-NASH. We have a lot of things to do in clinical practice. Of course, the hallmark is the weight loss. We need to promote weight loss. If the patient weight loss, we are doing the best for them, but also we can try to control metabolic disorder, like using anti-diabetic drugs. We can focus on inflammation, apoptosis, the gut microbiome, the immune response, and also, of course, using antifibrogenic drugs to avoid fibrosis progression. To do that, we have three possibilities. The first one is lifestyle intervention. The second is using drugs, and the third, using metabolic endoscopy or surgery. About diet, I would like to give you a couple of ideas. The first is not the amount of calories the key point for NAFLD-NASH, and we need to keep in mind that the micronutrients play a relevant role. In this study, in 45 diabetic patients, 8 weeks, with a high carbohydrate, low fat diet versus a normal fat but rich in monounsaturated fatty acids, olive oil, you can see how olive oil promotes a reduction in the percentage of fat concentration using magnetic resonance spectroscopy by 29%, in comparison with a low fat diet that decreased just 4%. And on the other side, on the left side of the slide, you can see a very nice study with 47 overweight patients that were invited to drink 1 more liter every day. They have a standard diet, but drink 1 more liter of Coke, milk, Diet Coke, or water. In spite of the amount of calorie of 1 liter of regular Coca is 430 and the milk is 454, is higher the amount of calorie of 1 liter of milk in comparison with 1 liter of Coke, you can see how Coke promote an increase in fatty liver 140% in comparison with milk without change. Therefore, we need to move beyond the calorie, we need to keep in mind the micronutrients, and we need to separate protective versus aggressive micronutrients. Fructose, glucose, HR elements that could promote the progression of the disease, saturated fatty acid against monounsaturated fatty acids, is the olive oil, or polyunsaturated fatty acids as the sunflowers, but also micronutrients. They are very, very important in the evolution of this disease. Vitamins, choline, selenium, carotenoid, or coffee. Coffee could protect the liver from the aggression of other micronutrients or any other factors. Together with the diet, we need to address the physical activity. We need to convince our patient that they need to do physical activity, but doing physical activity is not just to go to run the marathon. They can do many things. The first is to avoid sedentary behavior. The patient needs to avoid to spend many hours watching TV, sitting on the sitting room, and if they like to watch TV, they need to increment the number of bricks. If completely different the impact on the liver if you are moving or not. Physical activity is our daily activity when we are going and backing, walking, or doing any activity, but during our daily life. Exercise is when you dress and you go out for running, for any sport. You can do aerobic exercise or you can do resistance exercise. It's quite similar, the result on fatty liver. It's very interesting to add to this exercise high intensity intermittent exercise, and it's not absolutely recommended vigorous aerobic exercise because it could promote a lack of adherence to this program. I would like also to summarize that we need to convince our patient that avoid sedentary behavior, to avoid low physical activity, and please avoid poor diet with high fat and low poly and monounsaturated fatty acid. It's curious how PNPLA3 promote the progression of the disease was associated with fat, but if a patient with a disfavorable genotype for example, PNPLA3-GG, that show an increases 1.5 risk of developing fatty liver. When this patient underwent a lifestyle intervention, the response is much better in comparison with patients with the non-desfavorable or much better than in patients with the favorable genotype. CC, the response is lower in comparison with GG. It means that a patient genetically predisposed to develop NAFLD-NASH, if they do physical activity or exercise, could improve the liver in a better manner in comparison with people that were born with the favorable genotype. The key point is to reach weight loss. Eduardo Villar Gomez demonstrated in Cuba in a cohort of 293 patients with NASH in the liver biopsy that underwent low-fat calorie diet, walking 200 minutes per week, a questionnaire, and also group session to keep adherence, to convince and to modify behavior. One liver biopsy at the beginning and a second one after 52 weeks of intervention, 1 year later. And you can see in this slide the summary of this study. Percentage of weight loss in our patient was classified lower than 5%, between 5 and 7, 7 to 10, and higher than 10. And you can see how in patients losing 10% of the body corporal weight, NASH resolution was appearing 90% of the patient, fibrosis regression in 80%, and steatosis improving in 100%. All patients losing 10% of the body weight improved liver biopsy. This is a very impressive result. We are talking about so relevant disease associated with morbidity, with mortality, and doing diet and physical exercise. If we achieve the threshold of 10%, we can cure this disease in the majority of them. But the other side of the coin is the percentage of patients achieving weight loss. Less than 10% of these 283 patients achieve 10% of weight loss. 90% lose less than 10%, and less than 5%, 70%. The percentage of body weight that did not add any positive effect was found in 70, more than 2/3 of the patient. We need to improve clearly the percentage of patients that could be beneficial for them, the weight loss. Weight loss is clearly associated with improvement of insulin sensitization, decreasing lipolysis, decreasing visceral adipose tissue, increasing glucose uptake, decreasing de novo lipogenesis, and improving all the pathophysiology of this disease. We, in this study, we also developed a NASH resolution calculator. It's a non-invasive method taking account the percentage of weight loss, the normalization of ALT, type 2 diabetes, NASH score at baseline and age, and we can calculate the possibility of the patient to achieving NASH resolution without avoiding the liver biopsy. In the LINK study, using liraglutide and GLP-1 agonist, Armstrong demonstrated that this NASH resolution calculator accurately predicts patients that under treatment with liraglutide did not achieve NASH resolution. That means we can use the NASH resolution calculator to analyze if NASH resolution is appearing in patients in which we are addressing the disease, focusing on weight loss. This is a summary. We are doing the diet, we can compute, and if the patient is in the low threshold, the patient needs drug therapy. If it's over the higher, we can keep quiet because our patient is resolving NASH. If we cannot achieve our goals using lifestyle intervention, we have 6 different drugs that could be used to treat obesity. Has been approved by FDA, orlistat, phentermine, phentermine topiramate, locarcerin, naltrexone, bupropion, and liraglutide, the agonist GLP-1. And in case we need to go here beyond the drugs, we can use metabolic endoscopy or bariatric surgery. At this time, to treat NASH, at this time, we have 5 different drugs in development now, and they are in phase 3, 4 of them, and 1 in phase 2, addressing different different therapeutic target: cenicriviroc, obeticholic acid, elafibranor, selonsertib, and semaglutide, liraglutide. This is the Flint study. Obeticholic acid is a very nice approach. Obeticholic acid is an agonist farnesoid X receptor, and this agonist could improve the metabolism of bile acid to improve the enterohepatic circulation, reducing inflammation and fibrosis in the liver. In this study, 283 patients, NASH resolution was similar in patients with receiving placebo or obeticholic acid, but fibrosis regression was found in 35% of patients receiving the drug versus 19% in patients that received placebo. From a safety point of view, obeticholic acid was associated with increase in total cholesterol and LDL cholesterol and a decrease in HDL cholesterol. It's not very comfortable for us treating a patient with NASH with a drug that modify the lipid profile in the opposite way. The golden, using a dual agonist, PPR alpha and delta, demonstrating in the phase 1b and 2a some metabolic effect. They demonstrate that could promote NASH resolution in the 9% of patients receiving placebo versus 19% in patients receiving the drugs. It's a little disappointing when we receive this percentage, at least if we compare with the result in hepatitis C, but we need to keep in mind we are starting a long time career. We are focusing, trying to improve the metabolic derangement, the metabolic disorder in this patient, and perhaps we need to look at for long time. The GLP-1 agonist, liraglutide, in the link demonstrate ability to promote NASH resolution in 40% of the patient versus 10% in placebo. It's a very well tolerated drug, promote weight loss, and seems to act in different therapeutic targets in the brain, in the pancreas, in the stomach, the bowel, and also of course in the liver, and is a therapeutic target that should be explored in the phase 3 or using new GLP-1 agonist. CCR2, CCR5 antagonists, also a very anti-inflammatory drugs, very interesting. Cenicriviroc has been used trying to avoid the activation of hepatic stellate cell. And in the Centaur study, the comparison between cenicriviroc and placebo demonstrate 10% improvement in fibrosis using cenicriviroc versus 10% using placebo. It's the double, it's a very low percentage, but we are treating patients with advanced fibrosis. It's very important to keep in mind because this objective is very important because we can offer a therapeutic option for patients in which at this time we have nothing to do. The last one is selonsertib, is ASK1 inhibitor, showing different activity on hepatic stellate cell, CAF cell, and hepatocytes, the junk that we have the opportunity to discuss this morning in a very, very nice debate. You can see how selonsertib 18 milligrams in comparison with 6 milligrams or simtuzumab, a drug that has been withdraw and show a similar result than placebo, you can see how 43% of patients with advanced fibrosis could improve fibrosis when receiving selonsertib, and also 20% of patients could progress to cirrhosis when receiving simtuzumab or placebo, and in patients receiving selonsertib, it's just 1 out of 33%. We need to add the improvement of the fibrosis and the non-impairment of the fibrosis to put together, and we can offer a therapeutic option for patients with advanced fibrosis. And finally, just the landscape of NASH. Many therapeutic targets, more than 33 different drugs on trial at this time, in different phases across the world, and perhaps in the future we need to put together several therapeutic targets, because if we combine these drugs we can improve liver disease, addressing from different point of view. I think we need to do a lot of effort, we need to work together, we need to analyze from the metabolic point of view, the fibrotic point of view, the apoptotic point of view, and trying to mix all these therapeutic targets in just one combination, able to promote NASH resolution and fibrosis improvement. And this is the photo of the Institute of Biomedicine of Sevilla, with all the people belonging to Celiver Group, our group in Sevilla, and participating in many of the slides that I'm showing you this afternoon. Thank you very much for your attention, and we are ready for discussion. It's a very, very interesting question, Jordi, and thank you for inviting me to be here discussing about NASH. No? Fibrosis is a need in the majority of the animal models in which we are trying to induce liver disease. Sometimes we are focusing on liver cancer, sometimes in NASH, or sometimes in the metabolic disorders. And until now we have not the perfect method that could put together all the alteration that we can detect in our patient. Metabolic disorder, inflammation, ballooning, and fibrosis progression to liver cancer. We need to modify, we can modify high-fat diet using, for example, choline deficiency diet together, or high fructose. We can modulate, but at this time we are not absolutely comfortable, and we did not have a final method to be used in clinical in basic studies. Sorry. Yes, I was thinking if discussing the pathophysiology, because it's a fascinating field. At this time we have many doubts, we have more uncertainty and dilemmas that true concept to transmit. But at this time I think when I try to convince you that we need to focus on different targets, the immune system is of course one of them. The immune system play a relevant role in the interface between microbiota, intestinal barrier, and the relationship between bacteria, fungi, and our cells. And we need to develop clearly this area, because the immune system definitely play a major role on this disease. And the idea and the scenario of the microbiota, I think, is a perfect scenario to address all these questions. Yes, definitely. The best drug in which we need to work is to include in a capsule lifestyle intervention, weight loss, physical activity. If we have this opportunity, can you imagine that we have drugs that promoting NASH resolution 90%, fibrosis regression 80%, and steatosis improvement 100%? It should be the perfect drug. All of us, we are prescribing this drug immediately. We need to put all this knowledge in a capsule, give to the patient, promote this weight loss and improve the liver disease. I am absolutely convinced. The idea of the combination therapy, we are moving in a very Cambian scenario. I would like also to remember you that we use some drugs thinking in theoretically mechanism of action, but we found a completely different action. We use anti-inflammatory drugs that show anti-fibrotic activity, and we need to, when we are thinking in the combination, we are not combining this same drug that we are using in clinical trial at this time. The idea is if you modulate the receptor of farnesoid X in the intestine, could show a paradox effect in comparison with the agonist on the liver, and it could modulate glucose metabolism. We need to think to define exactly what are the key pathophysiological target, the key pathophysiological point, and we need to develop how can we address that. For example, de novo lipogenesis is the consequence of the insulin resistance. Glucose is used for the synthesis of fatty acid. This de novo lipogenesis is a very high energy consuming, more than 7 ATP molecules for the synthesis on one molecule of fatty acid. We need to address de novo lipogenesis. We can modulate, of course, insulin resistance. Of course, we can promote weight loss. But if we are avoiding the activation of the hepatic stellate cell, avoiding the waste energy consumption of the novo lipogenesis, and also improving the beta oxidation of the fatty acid, perhaps we are addressing the disease like in the nature the pathophysiology is driving this disease. Absolutely, we need to keep in mind all time. We are trying to use a surrogate marker, is how change fibrosis 1 year to 2 years apart, but we need to keep in mind all this time that the disease starts many years before, when starting the different metabolic regimen, and we will be for a long time if we have the opportunity to achieve the survival of the patient. And when the key point, for example, is if we are promoting this improvement, is a patient weight loss, not just drugs, weight loss, and improve the liver biopsy. Are we recommending you can regain the weight and you can keep watching TV for 12 hours per day? No, we need to keep the same therapy. This idea is if we are modulating the metabolic alteration, we can improve at the end of the day survival and reduce outcome. But we need to demonstrate that. Many trials at this time, they are designed to 5G follow-up of 5 years, and perhaps longer follow-up is required, because we need to keep in mind that these drugs should promote an improvement of the liver. It's very nice, it's very important, because until now this patient did not receive any therapy addressing this endpoint, but we can't forget that the patient is an overall, and we need to take care of him in any of the different comorbidities, no? Balancing safety and accuracy and efficacy. From my point of view, for primary care, we need to use serum biochemical non-invasive method. And combining these three methods, I think we can classify correlate patient at risk of or not. Using EPAMED fibrosis score, the NAFLD fibrosis score, and the FIB-4. But perhaps we need to address just people on risk of suffering this disease. Obese people, diabetic, metabolic syndrome, hyperechogenicity in the ultrasound, and altered liver function test. In this 5 group of patients, we can use this method. I think we can lose some patients, and we are not sure if we did not detect patient with NASH without fibrosis, if we are losing a patient at risk of progressing this disease. We need to take care of the patient for a long time, for many years. At this time, we need to focus on advanced fibrosis, people at risk of developing outcome and shorter survival. And I think it's, from my point of view, using this non-invasive method, we can refer to the clinical outpatient office. I think these 33 different drugs that are under development, but all of them show different strongness and weakness, and for me it's very difficult to select which one could be the best option. I think the best drugs need to be, I don't know if designed, but need to be developed in the near future. Until now, I have many concerns, both on safety, in several drugs, and also in efficacy. Of course, we need to keep in mind that we can improve a lot liver disease using drugs controlling the metabolic disorders, but it's very for me. I didn't fall in love. I'm very interested on GLP-1 agonist, but need to be put inside a capsule and to be eaten with the meals, no? Because an injection every day, every other day is absolutely uncomfortable. Of course, it's very nice because promote weight loss. It's the same that we can do with lifestyle intervention and the other capsule. At this time, we need to wait, we need to work, we need to develop and to demonstrate the final result of this large clinical trial, including more than 2,000 patients. And in 2019, 2020, we will have data to start making decisions according to which is the best combination. I fully agree. During many years, we have not taken account sleep disorders to analyze what is happening in the liver. We start with the circadian rhythm, with the paraencephalopathy. But curiously, recently, this autumn, Shira Salve-Sahi from Israel, from Tel Aviv, report in JAMA a paper demonstrating that people with NAFLD NASH show a reduced volume of the brain. It's the first demonstration and any impairment in the brain in patients with NAFLD NASH. No? And they try to look for different pathways communicating the brain and the liver. It's just a speculative paper, but the sleep disorder were included as a consequence of this morphologic alteration. I fully agree, we need to keep in mind, we need to include in all the studies, we need to analyze, and even perhaps we need to use different rings and watch to know exactly how many hours the people are sleeping and how could impact on the metabolic derangement and the liver disease. This is a very, very important point because sometimes we are combining different things and say, no, if you are, for example, all of us, I'm sure if I'm asking you, people with sedentary behavior could be sportists, could run marathon, yes or not? The majority of you, I think, or not, answer me. Do you think people with sedentary behavior could run marathon? It could be. It depends on the number of hours he is spending on the sitting on the sitting TV, watching TV. And if you spend more than 10 hours per day, you are suffering from sedentary behavior. No? It's like a joke. I don't know if I'm out of time or more than out of time. I'm sorry, but a patient in my outpatient office told me that he was suffering from NASH and obesity because he's playing paddle 3 times per week. Wow. No. I'm a paddle player. I'm going 3 times per week. One day I can play because I suffer pain in my leg, another my shoulder, etc. But every day that I'm going to the paddle, I'm having many beers, many tapas with my friends, and also when I arrive at home, as I'm an sportist, I'm doing paddle. I don't need to avoid my sedentary behavior, and I spend 14 hours every day sitting on TV. This is true, and we need to keep in mind that the patient needs to address all these different aspects. Sleeping well did not mean sedentary behavior or not, did not mean physical activity or not, did not mean exercise or not. And it's very important in the relationship between the physician and the patient to convince in all these different aspects, because they are completely different.
Okay, I think we are out of time. Thank you, Manuel, for your excellent talk. Merry Christmas to people from Barcelona. I think this first part of the liver seminar has been very, very successful. So I hope that the next year we will have more success in our liver seminars. Merry Christmas to all of you. Bye bye.
Merry Christmas and congratulations, Jordi.